Hey, everybody. Welcome back to another episode of the Vitality Code podcast. I am Dr. Jason Farrah, alongside my co-host, Dr. Jeffrey Farrah. Jeff, how goes it, my man?
It's going good, brother. We're getting a little cold weather down here in Tallahassee, so it's nice to see.
Yeah. What about so what do you do with the cold plunge life?
Cold
Hashtag
plunge
cold
life
plunge life.
when it gets cold outside.
When it gets cold outside.
Man, this is cold plunge weather. I love cold plunging when it's cold.
Oh, you like it? You actually like it better when it's cold.
You
really like it better, or you just think it's more of a
it's more of a challenge.
I mean, more of a challenge.
It's more painful.
Yeah.
A couple of things happen. I think when it's cold out, if you're standing outside and you're just shorts and no shirt on, no shoes on, and it's 30 degrees out, you're already cold. Yeah. It's there. You're doing it whether you get in the water or not. So there's not that drastic shock. And then it is much more challenging to do it in the cold weather. Plus, you can do open water swims now, so you don't have to be in a plunge or an ice barrel or something like that. We can go out in the lake.
Yeah, I've seen you do that in the you and Stacy posted one last year, I think it was, when you did the lake.
Yeah.
And I've seen ones in Colorado too.
Colorado, because they got the snow melt. They got that all year round. But here in Florida, we got to wait for it to get cold. Yeah. So I love to go out to Lake Mystic. Shout out to my people in old Bristol, Florida.
Bristol.
the least populated county in Florida, Liberty County.
Is it literally? Is it literally
the
least? Oh,
it is. Yeah.
Hence, most popular with you.
There you go.
That's right. And it would be with me too. I mean,
it's an inverse relationship for me.
Yeah.
Yeah. So this is cold plunge weather. We just got our outside container sauna finished. We just got electric hooked up. It's all cedar lined, and then we got our breathing room container all done. Electric is up and running. Just wait for the city to give us.
Whoa! There's a lot to unpack there. This sounds cool. What do you mean your breathing room? What is it? How does a room become a breathing room?
All right, Nick's about to show you the picture we took today of one of my members. Look at how good that turned out.
That's awesome. The beard, it looks like a Norse god or something like that.
That's my man Marcus right there. Shout out to Marcus Edenfield. That's one of the original mermaids.
Hey, if I start doing cold plunge more often than I am now, can I get hair like that?
Will you get that?
That is awesome.
Doesn't it look good? We shot that today. He's our member of the month at the gym, so that was his photo shoot.
Yeah, no kidding, man. Like in the ice, wow, who shot that? That is, Nick. Okay, Nick, you're a producer. You're a techie. You're a tech wizard. I mean, come on, you gotta bring that back up. That was that's you know what? Send that to National Geographic, man. That was
we caught him in his natural element.
There he is. Marcus is his name.
Marcus Edenfield. Yep.
Marcus, you're a handsome.
He's one of the
Marcus.
3 original mermaids. They started calling us the Little Mermaids because we would pull out of our CrossFit classes on Wednesdays and we would go do our cold plunge when we first started. So they called us the Little Mermaids.
Who took the picture?
It turned out
Seriously.
good. A patient friend of my GM, Charlotte. Yeah.
What was it? What did you use to take the picture?
Oh, she just took it today. Montana just sent me the photo, texted it to me from the photo shoot. I wasn't there.
So funny that went right over your head, didn't it? I meant like iPhone, like.
Oh no! I think I'm straight up professional camera.
Okay, I was gonna say because it looks.
Yeah. No, she's a photographer.
Good. Oh, okay. There.
Yeah,
that's
she's a photographer.
Badass. Okay.
Yeah,
nice.
So it's cold plunge weather, my man.
So hold on. So that was the outdoor cold plunge in some kind of bucket thing. Or something.
That's the ice barrel.
The ice barrel. Okay. And now but back to this breathing room. What's the deal with the breathing room?
So the breathing room, we have a shipping container, standard, 40-foot shipping container that we brought in and have retrofitted it. And we cut a giant hole in it, put 2 9-foot sliding glass doors in, and put flooring in there, painted it, put electricity in there, put a mini split for heating and air conditioning, and it's going to be our breath room. So we're going to do Stacy's individual somatic sessions. We're going to do our breath work, and then we're going to have our self-guided breathing stations set up in there.
Now, why? I'm totally ignorant to the breath work. So why would you not just go outside and do breath? Or why would you go in a room like this?
Yeah, the room is not necessary, but we are using it as a dedicated space at our gym because we were using the PT area and they started to conflict, so we needed a dedicated space. So there's a room. There's going to be some iPads and some Beats headphones and some MoonPod beanbags set up, so you plop in, bring up your session that you want to do, your guided breath work, and then we also hold our classes. We do breathwork classes. We're going to hold those in that space.
Oh, so
we have like 8
that's
to 10
interesting.
people.
Well, I would say like if you set aside this one space for that and made it, I mean, I think just that intentionality from the people who are providing it then translates into the intentionality of the person who is performing the breath work or doing it. I mean, I would think, right? I mean, I'm going to go into this space. My mindset's changing. I'm going to do this thing in there for this purpose. So I could see the value in that, but I didn't know if there was some kind of other physiologic reasoning or something like.
No, there's no special room about it. It's just a dedicated space at our. Yeah, that's kind of what our container looks like. Yeah, we don't have the home decor in it, but it's cut out with the glass across the front. Giant.
Wow, nice job, by the way.
I have to get a picture of it. It's actually it's got that space they cut out where that window is. The guy turned that, the contractor, awesome contractor. He turned that into an awning, so there's an awning sitting over the glass.
He used the excess plastic or whatever it was to. Oh, very cool.
The excess metal to cut it out and framed it in this industrial metal.
What you just gave us? You just gave us a free business lesson too, because you didn't have that space, but then you just used a modular unit to make. That's pretty cool, actually. Just gave me some ideas
there's some great building code reasons why.
I was gonna say, was that hard to get past the city of Tallahassee?
No, actually, the city of Tallahassee is the absolute worst for building. If you want to do anything of any significance in Tallahassee, do not try.
Shout out to Tallahassee.gov.
Shout out to Tallahassee.gov. There was no love lost. They put up roadblocks at every single point of the way, made it entirely difficult to. We completely renovated and gutted this just desolate building that was an old auto repair shop and was just trashy and nasty on this corner of the city, and they just put up roadblock after roadblock after roadblock. The city of Tallahassee was awful.
Ron, are you listening, DeSantis?
Yes, please.
Come on, you would think old Ronnie would get behind that and help you out.
He's not going down to the city level, but nonetheless. So we use that as a way to increase some square footage without having to go through extensive, ridiculous. When building code meets backwoods, good old boy, it is an implosion of ridiculousess. Did you talk to Bobby? Because I don't think Bobby likes his wood that way. You're like, well, the city, the standards are right here from the federal guidelines. Like, I don't think Ron likes his wood parallel. He likes it perpendicular. And you're like, where's that written? It's in Bill's handbook. And you're like, okay.
Yeah.
That's so. Nonetheless,
Bill and Ron. Those two knuckleheads.
So but nonetheless, I digress. We don't want to go down that.
You didn't have a bad experience at all, did you?
No, not at all. Not at all. If anybody's talked to me for any length of time, which is anything over 30 seconds with the city of Tallahassee's building code,
if you ever had an axe to grind, that was the one.
Yes, I will. The cops weren't ever called. No, I'll just leave it at that.
Well, I mean, it is kind of frustrating when you. It's not like you're trying to set up a cocaine dispensary. I mean, we're trying to help people with their health, and like make the community healthier. Can you just slow us down as much as possible, please? Jeez.
Well, we had our own FBI investigation here in Tallahassee when our own city government was doling out projects for dollars, but I wasn't doing that. But trying to do a renovation, at least I didn't. I guess I didn't grease the right pockets.
That's why you weren't, because you weren't helping out with a.
Yeah.
Come on, you weren't.
If you want to look at a nice little subset of Tallahassee, look up our former mayor as he ran for governor.
Oh God, was that Scotty?
Well, that was the one before him. You can go back and you get good stories. We won't talk about that. There may have been some methamphetamine. There may have been some prostitutes. There was,
It's all public knowledge too. It's all
public knowledge.
We're not.
I know no details.
Yeah, exactly. Well, dude, you know what I've been seeing? Well, I've been seeing for a long time from Peter Attia. And then, there's a lot of interest now in fasting, zombie cells, and I think that data is pretty compelling, honestly. I really seriously. I mean, some of this stuff is kind of fad-like and cult-like, and I think it's on the fringes, NAD and stuff, which I was really excited about. Then I looked at the literature and I was like, meh, I don't know if that's really, I mean, I think a lot of the stuff has signals in the literature, and I think there's promising stuff that's yet to be elucidated. But the fasting and the glucose homeostasis, glucose monitoring, ketone monitoring has really been interesting to me a lot. And I see a lot of people walk around with the little
patches.
Yeah, and I mean I've been seeing that more and more. And I hear tale that there might be some CGM going on over at Midtown.
Yes, we do dabble in the CGM, so that would be continuous glucose monitoring. Yeah, I check an A1C on every new patient blood work that comes in. So that's a standard. I don't have to participate in insurance protocols, so I don't need to have a known diabetic potential to run my A1Cs. I run A1Cs on everybody. And then
hold on a second. This is interesting. So a couple questions arise. When you say everybody, do you mean all testosterone patients, or do you mean all patients, period?
All patients, period.
Okay.
Yeah.
So I think I think you're ahead of your time there, only because what I see clinically in getting that same smorgasbord of labs for new testosterone patients, what I've seen is people that had, by self-reported measures and records, no incidence of glucose homeostasis disruptions come in with we've diagnosed diabetes in, I don't know, just oodles of people, or pre-diabetes. And so I think you're I think
1 in 10 Americans are diabetic, and another 84 million are pre-diabetic.
It's insane, dude.
That was as of 2019.
Yeah, and then
so
you got this
increased.
epidemic of diabetes, right? I mean, like everybody's, and so I just think that's probably smart. So anybody that comes in for anything.
Yeah, so we check A1Cs, and so what your A1C is, let's talk about what that even is, because a lot of people, doctors do a really good job of just having the nurse call you and say your labs look good, see you next year, right? But they don't ever tell you what anything means, or we don't go over anything. So your A1C is a 3-month average of a 3-month inferred average of your daily or moment by moment glucose throughout 3 months of time. And it's taken
hemoglobin,
so it's how much of the sugar, as I described to my patients, is how much sugar is dissolved on a red blood cell. And red blood cells on average live about 90 days. And so hence a 3-month average. I learned this from Peter, and I had Peter Attia, and I don't know how accurate it is, and I don't know that you would know, so I'm not asking for an explanation. But people with microcytic red blood cells, smaller red blood cells, he states that they will sometimes bypass splenic destruction of red blood cells more readily, so they tend
filter through. Yeah,
so they tend to live longer. So you get an altered, false elevation of hemoglobin A1Cs. This is one of the reasons he doesn't like A1Cs, is that if you are microcytic in your red blood cell formation, your red blood cells are going to live longer than 90 days. Hence, they will be more saturated because they're living longer. Hence, your hemoglobin your A1C will be falsely elevated on a hemoglobin A1C test. And so for him, he used himself as an example. I don't know how accurate in this information. I didn't look into it, but his was up to a 0.5 difference, right? So hemoglobin A1C is a small range. If you are optimal, as I explained to my patients, you're probably 5.1. If you're diabetic, you're 6.4. So it's a pretty small range of numbers.
And pre-diabetic, at least on our lab, is 5.7.
5.7 to 6.3. Yeah. So a difference of 0.5 is a big difference. And he's saying,
I agree.
He's saying he's seen in his personal data, his own blood, he's seeing a difference of 0.5 due to the presence of microcytic red blood cells.
I want to just interject here. I don't have any problem with that. I actually tend to agree with the sentiment, and I would say even further, if you look at Ralph DeFranzo's work, the man who holds the most NIH grants for diabetes research in the world, he's out of the University of Texas, Houston Health Sciences Center. The A1C has issues in that it's not as accurate in terms of pancreatic function, levels of insulin in the blood, and your tolerance to glucose as defined. Excuse me.
Bless you.
As defined by the like something like the oral glucose tolerance test.
Correct.
Because you're just looking at the glucose. You're not looking at how your body is managing that glucose. And so I tend to agree
like
with the sentiment.
Because it's easy and quick. I use it as a screen, right? It's
yeah,
not a
a screen.
diagnostic test. And
Right.
I explain this to sometimes to patients about different things like mammograms versus MRIs. It's not diagnostic. It is a screen. So you can apply it to a large population across a broad spectrum for inexpensive
Well, then,
dollars.
if it's not diagnostic, what do you use to diagnose diabetes?
Well, so
Or
good
what
question.
What does the diabetes? I mean, what is the endocrine association?
So yeah, so it is according to the societies, according to your insurance company, it is diagnostic. So 6.4 is the diagnosis. I should have said that differently. It's not always indicative of ideal glucose and insulin relationship. It's not always a clear picture of whether or not you are slipping into metabolic dysfunction.
Right.
But it is diagnostic as defined by the people who are paying your bills when you're going for medication. It is diagnostic according to the endocrine societies currently. So 6.4 is that. It's that now. But I use that as a good quick screen. I explain it to patients as a good way to address that. But I also like to look at continuous glucose monitoring if there's a couple potential things that come up. So I like the continuous glucose monitoring, but it's much more involved, not dollar-wise, but patient-wise, and your staff, and you have to be set up to ready to interpret that data, get the data, and all that kind of stuff. So it's not as quick and easy.
So how are you doing it at mid? I mean, not as quick and easy because it's not just a singular lab draw. You have to wear the monitor, and then the data. You have to do something with all this data that's coming in.
Right. So a continuous glucose monitor. It looks like I tell patients, it looks like a $50 size. It sits on the back of your arm, or you can do your stomach, back of the arm. I think is most common, and it communicates to your phone, and it gives you readings at about a 5-minute interval throughout the day without you doing anything of your interstitial glucose levels and how that is. So you're going to calibrate it when you first get it. Ideally, you can calibrate it to a blood stick. Most people don't do that. It's pretty accurate in terms of its data as it correlates to your blood levels. And throughout the day, it uploads this, and night, it uploads this data to your phone. And so at the end of a day, 3 days, 4 days, now a week, 2 weeks, you have this graph of what your body is doing with the food you're eating, the insulin you're spitting out, and your glucose levels subsequently. And so what I tell patients is, I draw a couple different lines. And I just draw a flat line, and I draw a really wavy line, like if you can imagine sound waves. And we don't want the sound waves; we want the flat line. Now that's okay. Yeah, so it's not exactly what's happening. And so I can hear you crunching that ice, brother. What are you doing over there? What are you drinking?
Nothing with sugar in it.
There you go. Yeah, or caffeine.
That's right. Actually.
So what I see is I want to see people leaning more towards a flat line and less fluctuations. So what I see in my people who are starting to get insulin dysregulation is that you're going to start getting patterns that mirror what a diabetic's patterns, even if you aren't diabetic. So if your average, i.e. your A1C, is still 5 point whatever, and you're not diabetic.
This is the point, yeah.
But your fluctuations going up to 140, down to below 70, up to 140, down below 170, that average might be okay, but the dysregulation is started because you're getting these fluctuations. Nick, can you bring up that I found this little thing right before we came on, and it brought it up. So here's what you will see people's different blood glucose doing over the day. The top left on my screen, that where it says low, that's kind of a typical pattern. And I don't even like to see those spikes and valleys. Then you move to the right top where you see borderline, then you see high, extremely high. So the greater the peaks, the more V's that we find, the less regulated you are. I want to see what that looks like over the course of time, and I want to see it much more flat. The other thing that I want to see.
Wait 1 second. Hold on thought. So could we say that these are 4 different people? Could you say that? Like, oh, this guy over here on
Yes.
the top. Okay. Now, the one thing about this though is what if let's talk top left corner
Mm-hmm.
where it's low was
Mm-hmm.
eating bake or was eating I don't know lean pork all day or steaks all day, and
Mm-hmm.
then the guy over here on the bottom right is not necessarily a function of the homeostasis as much as it is the consumption. Like, what if they were eating something that was high in glycemic index, like
That's
Snickers or something?
100% what's happening. Yeah. That
Oh,
that
okay.
yeah, this is in response to food intake. This is a whole day.
But I
And
mean, like, but don't they all have to eat the same stuff to know? Like, what if, like, in other words, if top left was eating just lean meats all day, but then you gave him the diet of bottom right, he might look
mhm,
like bottom right. Do you know what I'm saying?
that's exactly what happens. So I use this. I don't use this to establish a phenotype. I don't use this to establish your style, or I use this to change your diet and your timing. I generally, what I tell
Oh,
patients is
okay.
there's two things that we're going to get from this information. We're going to change the timing of your food intake. We're going to change the specific foods that you eat, and then lastly, there's going to be one, maybe two items that you will no longer be able to eat, and that will be
Oh,
different
okay.
for everybody.
So you're looking at their response to their diet and how they're okay.
Correct.
Okay, cool. Okay, I got you.
Yeah.
I
So
got you.
what you
This is
see is
very cool.
you move more towards that extremely high graph. The more carbohydrates, the more refined foods you eat, the less fat and
Okay,
less
okay.
protein that you eat.
Oh, this
In
is
terms of
cool.
food intake, you will move more towards the low based on the food that you'll eat.
Okay,
There is
okay.
also some really, really specific individuality that comes with insulin and glucose and food digestion and processing. I tell everybody, and I've seen this across the board with my small n number, but there is always at least one food that you are eating that wrecks your blood sugar, shoots you up to 200, and you don't know what that food is. You
Wow.
have no clue, right?
Yeah, you have no
I
idea.
can put syrup on pancakes, on cereal, doused with ice cream, nothing. I eat Chinese food, blood sugar 215.
No, no, is this literally what you're? Is that you? Literally, or are you just an
Literally,
example?
no, that is me literally.
Really?
Yes. And so I tell people
Wow.
there's going to be something that you will no longer be able to eat if you want to adhere to an ideal glucose state. I've
That's
seen it from
fascinating.
health foods, like, oh, I was eating this diet meal because I thought it was healthy, and it was a bar, and I don't even like the thing, but I was told to eat it because it would help me lose weight, and it was crashing their blood sugar, right? Um, I've seen everything, right? So for me, it was Chinese food specifically. So I don't eat it anymore.
That is
But some people, so
fascinating.
there's always one thing. The other thing I commonly see, if we're talking about the diet and the modifications that come from this
Yeah.
information, is timing matters. Some people do
Yeah.
well with an early morning meal. Some people don't do well with an early morning meal. Some people need afternoon snacks. Some people don't. A common thing for timing is moving away from bedtime tends to improve glucose control while you sleep, which
Moving away
then
from. Okay, yeah.
improves your quality of sleep, which then improves the next day. There's this ripple effect that comes. So
Well,
what
and it improves your overall metabolism in general.
yes.
Yeah.
So if you eat late at night, and let's say this is your body could have handled this meal during the day because maybe you eat and then you walk around or you exercise or you run
Right.
after kids or whatever. But now you eat it late before you go to bed. You just lie down. Your body starts to put all that sugar away because it thinks you're going to eat again in another hour or two because that's your typical pattern. And then you don't because you're sleeping. Now your body starts to crash a little bit, right? The glucose actually
Right.
starts to dip too low. So then your body says, oh shit, we don't like that. It starts to bring it up. In that dip and in that rise, you tend to sleep really poor. You toss, you turn, you
Absolutely. Your
up and
adrenal
down.
hormones you jump up. Your epinephrine,
Mm-hmm.
adrenaline. Yeah.
And then it
Yeah.
starts this cycle.
Which hits your reticular activating system, which is your awake system.
Yep.
Yeah. So you get out of the wrong. Wow, this is interesting, man.
Yeah. So that's a pretty common one, is moving away from bedtime with our food.
How many hours, or just?
Yeah,
Or
I
is it,
don't know. I don't have a good data on that. I tell people you probably want at least 2 hours away from
yeah,
bedtime.
I've just randomly heard 3, but but two to three has kind of always been my.
And everybody's
go-to.
a little different, right? And so what I see the subsequent thing that happens is now the morning hits and you have slept like crap. You feel really tired.
Yeah.
So what do? You go to refined carbohydrates. You go to quick sources of
Well,
fuel.
what's happened is cortisol is released. I mean, yeah, it's like you're turning into a shift worker. Essentially.
So then you take your coffee with some extra sugar, with some, maybe get a blueberry muffin just to give me that quick hit because I got to get to work and I got to get up and running, and then that starts your cycle for the rest of that day.
Wow.
So timing usually it tends to move people away.
Let me ask you this: what about in the in the fit state? Like when you did this, were you at your current level of fitness when you found out Chinese food? I mean,
for me, pretty. I don't really go through many peaks or valleys fitness wise. I'm just kind of
so even in a pretty good fitness level, you were
over 200. Yeah,
that's insane.
Yeah, Chinese food was terrible for me. And so then what I tend to see with people is we start to eliminate a meal. We then start to add protein and fat to that is generally speaking an inclusion. I don't like to see pure carbohydrates. We cut out sugary drinks almost across the board. No more sweet teas, no more Cokes. They are atrocious. What you see is a quick spike. That quick spike causes a quick fall, and then you get hungry, and then you spike again. So your sugar is doing this. Yeah. There is some data that shows that this prevalence of spikes and valleys is more detrimental than just a stable high. So even though diabetes is a high, it's the spikes and valleys not irregardless, but in addition to that makes it even worse. Endothelial dysfunction, oxidative stress, increases in cardiovascular disease events over a 20-year period all come from that. So
that's fascinating.
Yeah, so glucose monitoring will give you that information. And guess what? It's inexpensive. And I tell people the best thing is there's no medication anyone can sell you. It's all on you. It's all data you can use. And I use it for my athletes working out. So in addition to like heart rate monitors, like are you just wussing out on this workout, or was your heart rate really through the roof and you're fatigued and dying? And we can look at, you should see a spike in from a super intense workout. I would want to see a spike in your glucose monitor levels, right? Your sugar should go up in response to a really intense workout.
Adrenal hormones.
Yes. They're all getting ready, like, oh, all hands on deck. Jeff's going for it. This is Olympics, so there's mobilizing all these systems. And then, but what you see is different than the spike from food is that spike from exercise can go just as high. It comes down and it levels off for a really long time. But the spike from food goes up, it crashes, and then it waves for a really long time, and you feel like garbage. So your long-term effect from an exercise spike is stabilization over the long term of your sugar. The result of a spike from terrible food intake is dysregulation over time.
For a long time, yeah.
For a long time, yeah.
Wow. So when you're with your athletes, trying to parse out, that was interesting what you just said because that resonated with me, and I've been getting back into CrossFit and HIIT and everything over the last month and a half, and my gosh, it's just like sometimes I'm like, I can't believe I can't do this, but my heart rate, I can feel the lactic acid. Like I literally can't contract my muscles. You can't
clear out the things. You can't mobilize sugar as well in response to exercise. Your heart rate is not able to be as high. So part of sometimes patients who or athletes who can't work out as intense as they want to, sometimes it's just they're able not to withstand pushing themselves to trigger this response to keep them going, this sugar dump that would fuel future exercise or in the moment, so to speak.
That's interesting.
So I use it as a marker sometimes of intensity of workout as well.
So what do you do to help them adapt? I mean, do they, if they're not getting the sugar, I mean, is that someone that needs a supplement with Gatorade? Or I mean, like, are they?
You would. Yeah, depending on your workout. Yeah, so training adaptation. So we're looking at we're going to look at this as a training adaptation over time. Your ability to withstand it, your ability to hit higher peaks. You might look at supplementation while you work out, depending on it. You might look at taking. Changing their style of workout or giving somebody the grace to say, like, this is going to take some time for you to adapt. You thought you were 20, but look at your heart rate is capping out less than what we think your max should be. You're not mobilizing like we think you should be in terms of a metabolic stance. Like you're a little bit undertrained and you're detrained. You need to give yourself some time to do this.
It's interesting too in the current modern world, and I've seen this. Like, there's something to this in terms of business where one of the things that people are craving is data, and we're so. I mean, on our phones, our brains are just now wired differently or adapted for just large amounts of incoming data constantly, and people seem to, oddly enough, I think there's definitely some maladaptations, but there is some desire for that, and certainly with behavior changes. And I think, sometimes one argument might be, well, that's just so much data people can't process, but that's not true. I think people really want this data. And they tend to make changes more often than not if they have that data.
That's a great point you bring up. So I tell people there's something that happens with this information, right? If I tell you candy's bad for you, if I tell you eating late's bad for you, we've all heard that a million times. It's not going to change your behavior. But when you bring up your phone and you see you just ate your meal and you're watching your glucose, okay, like, 100, 120, 130, 150, and you're like, oh God, I'm not eating that again, right? So that happens. It's real world information in the moment. The other thing I tell patients is we're not going to check your continuous glucose monitoring for the next 6 months. It's too much information. You're going to get a snapshot of just give me 4 or 5 days. It's a 2-week monitor. It doesn't usually last that long for active people. They just come off. But I just give me 4 or 5 days. We're going to make some changes, and then we'll revisit it again later to see what those changes did. So I don't want to inundate you with like, oh my God, I got to, can I eat this? Can I eat this? Can I eat this? You still need to live life, right? There's the optimal and there's the practical. And so I want to make some changes, and then we'll revisit this in a little bit. The packages, just from a practical standpoint, they come with 2 monitors in them. I use the Libre because they seem to be the cheapest right now.
Okay.
Yeah, they've gone through a few iterations. They had a coupon online for free. And then I think the Dexcom was a much better one, but I couldn't get it through some insurances, and it was much more expensive. And so I don't really use that unless the insurance will cover it. But I got my Libre off a coupon when I did it. And then the second one, I didn't have the coupon. It was $25. So you don't need to go to these online systems that are like, the ones online, not that there's anything wrong with them, but what I found the difference is they're the exact same monitors. They just have a really cool app platform, which can be helpful. I'm not trying to poo-poo on them, but you don't need to spend $300 to $500 a month.
Wait, give me an example. What do you mean? Online and
the app that you look at your glucose through.
Okay.
It gives you cooler graphs, better colors, fancier pictures, better interface, and there is something to be said for that. But I don't know.
And what's the other one? It comes with its own monitor or something?
It comes with its own app. So Libre system comes with its own app, but it just has limited interface. It's more medically oriented, and it's just sort of stripped down nuts and bolts. Okay. Here's your sugar. There's no shopping list to Amazon that are going to post to it. There's no cool little, people talking to you in graphics and red lines versus green lines versus blue zone, all the kind of fancy stuff, which is good, but I don't think it's worth $300 to $500 a month for these, these people that will now be in everybody's feed because they're listening to your phone right now. But but I don't think you need they don't need that fancy one, but not that there's anything wrong with them. I think those interfaces are good. The Libre is a stripped down one for sure, in terms of its app interface. The Dexcom was better, and it was more optimal, but it was a little expensive, and it didn't quite meet for me what I needed to do. I would love to find a way to get it inexpensive for patients and just have them stocked in my office, right? But you need that app interface, you need that technology, and so they're great. So we want to see. I tell patients we're going to set your parameters, right? It can give you alarms and things like that. We want 70 to 120 is usually what I put people at, so you can see quickly as you go out of that. And we want to limit spikes above 140. We definitely don't want to see spikes in the 200s. Those are not good. And we want to see. It's okay, and you should see an elevation when you eat. And it's okay, and you should see an elevation when you work out, if it's an intense workout. But you should not see repeated spikes and repeated peaks, and you shouldn't see peaks in the 150s, 160s of your glucose levels. And then there's this other phenomenon that I've seen in doing this is it seems to be mostly women. They come in with chronic fatigue. Their hormones look good. Vitamin levels look good. Labs look good. And then I started noticing this one lady in particular. Her A1C was 4.7. And I was like, oh, that's really low. Like optimal, most people, 5, 5.1, 5.2, 4.9. If you're a little carb phobic, you're an athlete. And she was 4.7. So I was like, tell me about your diet. Like, do you have specific restrictions? Are you on some keto thing? Nope. I eat whatever I want. You don't care about your diet at all? No, I've always been lean my whole life. It's not a problem for me. I was like, no allergies. She's like, no. I was like, well, your data shows that you're not eating any carbs, almost like you're like an ultra marathoner or you're a really keto heavy person. She's like, no, not at all. So
And what do you mean by that? Her data, like her blood sugar,
her
A1C super low,
4.7, her A1C 4.7,
or
and she's
just
not
ridiculously
watching her.
Good
Yes, not watching her diet at all.
Okay,
4.7. So I said, well, that's too good to not care. You're going to be tough to get under 5.0 and not be paying some level of attention to what your diet and your exercise.
Right.
So we put a glucose monitor on her, and lo and behold, we have these big spikes and big valleys, right?
Hypoglycemic or something?
But her peak was about 100, and her valleys were in the high 50s.
Huh.
So she's now not even close to diabetes. She's taken that whole model and shifted it down in absolute values. Her peaks and valleys look like that diabetic with the extremely high, but her levels are really low. And so she chronically dipped into really low insulin sugar levels of like 50s and 60s. And she's feeling fatigued, groggy,
so
getting a little nauseous. Yes, but not clinically significant to go to the hospital or something. But and so it was really weird to me. And it said, well, yeah, your hormones look great. Your testosterone was great. She still ovulated. Estrogen was good. I didn't see any other reasons why she had this chronic fatigue. So we started tweaking her diet. We got a little bit of changes. We got a little improvement. And so then I started noticing this amongst other females where we had this really low A1C. So I'm going to tell you to start looking for this. Really low A1Cs below 5, and someone who's not watching their diet at all. Put a glucose monitor on them and see how long they spend in these really lows, 50s and 60s.
I wonder, is there some issue with glucagon there? Like it's not being secreted?
I've gone down a small rabbit hole. And I couldn't find any subclinical other than like an insulin tumor.
Right, insulin secreting tumor. Yeah, it's too much insulin, or
it wasn't that bad, right? The thing I found with one of my patients,
surreptitious administration of insulin.
Yeah. Well, the thing I did find though for her, and this is now, she was the first one. It was related to doxycycline. She was on doxycycline for acne, adult onset acne, and the doxycycline was really affecting her blood sugar. I called the derm. He's like, nah, it doesn't do that. But tetracyclines 100% do that. I don't know that it's well described in the literature to the level that I was seeing. Yeah. Do a quick Google doxycycline and low blood sugar next time. And for her, we got off the doxycycline. Boom, fixed her symptoms.
Really?
Caveat: her acne came back. So now we were left in this place, and she's trying to mitigate and try to find that's the best thing that worked for her acne. This is a significant problem. So she kind of floats that line. But at least it answered that question to her. We didn't do any other treatments. We didn't do any hormones. We didn't do anything else in her. And so what is Nick? Oh, what'd you find, Nick?
I would say, too, don't forget they might need to get a CT scan, make sure it's not an islet cell tumor. I mean, or at least get an insulin level, like a C-peptide level, Sure.
Yeah, there's always the outliers. There you go. Yeah, interesting. There's a lot of case reports is what I found. But this one was just having like almost a subclinical.
Very interesting.
Yeah.
Go back, Nick. Go back. Does it go down to the conclusion? Does it give a pathophysiologic theoretical mechanism and what in the hell's happening?
Yeah, I couldn't tell you what that would be.
Discussion. Proposed mechanisms. Right there. Increase insulin sensitivity.
We'll leave that for your next talk, Jason. You can dive us down the science of it.
Yeah, interesting. Okay, yeah.
Yeah,
Okay.
and so I haven't seen this with a lot of patients, this really low A1C, but I had my first guy come in the office last week with a A1C, again, 4.7. And I was like, first time I've seen a male. Nope. But I was like, I'm going to put a glucose monitor on you, right? Testosterone was not ideal, but it wasn't significantly low and not enough for me to jump on I got fatigue and I want to treat it. Without fixing, I wanted to fix the potential hypoglycemic issues first, and we're look at his diet before I jump down that. So I would tell physicians or anybody looking at that, look for really low A1Cs, right? You breeze across them because they're not diabetic, so you don't care anymore, right? You're always looking for all this diabetic. But if you see something lower than a 5, just ask the question: are you specifically on a carb low diet? Are you specifically watching this? And if not, consider this glucose monitor, and you can help people by changing their diet.
But do you find
timing.
that you? I agree, and this is. I mean, I'm really interested in this now because there is a lot of. Well, no. There's a significant subset of patients where I seem to optimize their vitamin levels. I seem to optimize their hormone levels. I seem to optimize, I don't know, other parameters, but I just can't fix what they're wanting to get fixed, or some percentage of what their symptom complex is unfixable, and it often is described as fatigue or not feeling right, or thyroid's fine, and and they're on B12 shots and blah blah blah. I wonder, would you say your practice before CGM was similar, and CGM helped you at least help some other subset of patients that you weren't prior able to help? Yeah,
for sure. It elucidates. It's quick. It's easy in terms of like you look at a graph and you could just see it from across the room. And you're like, yeah, you got a problem here. We got to fix, right? And it gives them hard data. It's not some abstract number based on some scale they have no idea about. And you're talking about hemoglobins and A1Cs and red blood cells, and they just look at. They're like, yeah, and they can log in the glucose monitor. I had an apple and a turkey sandwich. I had Popeyes. I had a nice cut of lean beef and asparagus, whatever they're doing, they can see the response. So some people do more than others, but it's good. I think the best I've ever heard, again, Peter Attia is big on this. So if anybody want to get some more information, he's a good resource, but he was talking about his data and his peak from when he was speaking of his, and I forget if it was a 30-day or a 2-week or whatever it was like his peak was like 109 and his valley was like 75 or something. And I was like, man, I'm jealous. That's a really good line, man. That guy's really paying attention to his eating, his exercise, and his data, and all that kind of stuff.
So when you get people from this to this, would you say 100% of the time or near 100% of the time whatever it is, and we can go.
They feel better.
They feel better.
They feel better. Yeah, and it's such good data. So what happens is the other thing too to remember, those spikes cause big drops and valleys, which make you hungry, fatigued, cause you to eat again, which then causes another spike.
Right, it just makes it
and it's self-feeding.
Classic.
So
I had no idea what you were going to talk about with this. Yeah, I'm gonna institute this immediately. I mean, this is
and awesome. There's some interesting. You can look at they call them glucotypes, just people's anatomy, physiology, DNA that handles insulin, sugar different. So that would be like what you were describing in the beginning, right? If we were both eating pork or we were both eating a blueberry muffin, you're going to treat it different and I'm going to treat it different.
Yeah,
I would make an argument that we are different glucotypes. I think you lean more towards...
You mean me specifically?
You specifically and me specifically.
Based on what?
I think you lean more towards dad's genetic type with the cholesterol, and I lean more towards mom's genetic type with the diabetic tendencies.
You're saying okay, you're going to get diabetes and I'm going to get cholesterol issues. That's if we're maybe. I mean, Why? What was your A1C?
I was on prednisone for such a long time, and we got a debate about that. So, and that's a rabbit hole we probably don't have time to go down. But the doc told me when you're on prednisone a long time, it doesn't cause diabetes; it causes you to get the diabetes you were always going to get. And I was like, I was a little bit of kick in the pants there. I was like, well, how'd you know I was going to, but my A1C was 6 when
what?
6. Well, this was on prednisone was 6. I can't remember if it hit 6.4 or not.
Wow. And was
I started metformin while I was still on the prednisone, got it down to 6, and then I got real detailed with my diet, got off the prednisone, got off the metformin, and I'm hovering around 5.6 to 5.7 now.
Even with optimized testosterone?
Optimized testosterone, optimized diet, intense exercise. Like that prednisone screwed me really bad. It's rough stuff.
Well, right. If you have a constant outpouring and a glucocorticoid effect, you're
for decades.
So what? Right. So so you just burnt your pancreas out. Is what happened. I mean, that's just literally what happened.
Yeah.
You're probably working on 15-20% of your pancreatic. You're innate or born with pancreatic.
Yeah, I have to work twice as hard to get half the results for sure.
Yeah. Wow. This is phenomenal stuff, man. I diabetes and obesity. Diabesity is becoming, I don't know, it's the biggest chronic issue of our time.
Yeah. 1 in 10 Americans diabetic, and another 84. So that's about 30 million. Another 84 pre-diabetic.
I want to revisit this. I'm going to start doing this in the clinic, and I think.
What if both of us? There you go. Just by Heather Hall. Yeah, there you look at. Dang, Nick, you're getting good, man. That's the article that was the specific article I was referencing.
Wow.
Yeah, that's a good one. It's not a quick, easy read, but it's a good one. It talks about 3 different kinds of patterns. It's a good one to reference.
Actually, Nick's wife is a nutritionist who specializes in diabetes. So he's got a little bit.
We got to bring her on. You cheated,
Nick. Maybe we should. That would be interesting. Wow.
Yeah. Maybe we should put glucose monitors on all of us and put our graphs up there.
Actually, let's do that.
Oh, God,
I'm gonna do that. Yeah.
You want to do them?
Yeah, I'm gonna do it. When do you want? How long do we need? Like 3 months or a month?
No, 3 days.
Okay,
Data. But so here's what I would do. Let's do this too, because I think this is important, right? I want you to write a script, or have Morgan write you the script, or whatever. And I want you to talk about how easy it was to get, how hard it was to get, how much you had to know going in there, all these things that people don't talk about. They're like, oh, do this, and then you go and you're like, CVS is like, oh, we don't have that. Oh, your doc wrote it wrong. Oh, your insurance doesn't cover. We didn't fill it. Like all these little roadblocks.
I can't just go on Amazon and buy one.
I don't know. We'll find out. I don't think you can.
I'll find out.
You can go online. I guarantee your Instagram's flooded with ads right now, but they're really expensive. But just find out, see what it's like to be a patient. It's not always easy. And so I think a lot of times the roadblocks that we talk about, like, oh, docs should be doing this and docs are doing this well. Yeah. And then you see man, it's a pain in the ass just to do something what my patients need sometimes. And so it would be interesting to hear that side of it. And then Nick will get you on one, and maybe your wife, and she might beat us all.
She ball right should. Yeah.
Yeah. And then maybe, I was thinking I could put, I have a 17-year-old daughter. I could put Bird on it. We'll see what optimum looks like a 17-year-old metabolism.
Who's in beast mode, physiologic shape, CrossFit. Dude, I've been looking at the IG picture. I'm like, oh man, she's totally getting that CrossFit frame now, man. She's turning into a genetic freak,
weight,
man.
Though. Yeah,
she's a hard gainer, but she's getting some muscle in her thighs. I see that.
Oh, it's God, sure. Yeah. It's forced her, I know we're going on a tangent, but it's forced her to perfect her form to lift at the level she's lifted at. So when that muscle does come, her form will be impeccable. Yeah. So it's interesting to see.
It'll get better with age. Man, this was a good one. This has really opened my eyes. I can't wait to dive into this.
Get you some continuous glucose monitoring.
Yeah, dude. You know what I'm gonna do too? I'm kind of excited to get to do this too.
What?
I'm gonna go to. I'm gonna get some Kung Pao chicken. Some.
See how bad it gets.
I gotta see. I want to see what. Yeah, I am. Honey, we have to do this. This is for science. This is an experiment we have to do this weekend for science. I'm really excited.
That would be pretty cool to see different food types. Yeah, maybe I'll get some of mine too, and we'll do it. Nick, what's your favorite meal? Pizza. All right, interesting.
He's Sicilian, so come on. Yeah.
There you go.
Yeah, look at Mark Andrews. Oh shoot! Look at
He's
that.
type 1
Wow.
diabetic. Yeah, so that's a good thing we should mention. This is type 2 diabetics that I've been discussing, and people leaning towards that. This is not, but the wearables for type 1 diabetics, these glucose monitors then communicate to their insulin pump so that they can then push out insulin. Like those,
I've seen them in
that's
trauma
really cool.
patients.
Yeah, the
Very
wearable
cool.
space is going to be really cool.
But Nick's point's not lost either. I think there is getting more and more in the popular mainstream. Either way, it's getting out there. Yeah. So
yeah, if you want a really great, succinct, deep dive, both really deep and really succinct, Peter Attia has a couple great ones on this. Like this is his bread and butter. This is his baby.
That's his bread and butter. I'm not a fan of all things Peter Attia, but just like anybody, I mean, like nobody knows has the answer for anything. So nothing against him, but that he is the man on that stuff. Yeah. Absolutely. Fasting, ketones, and glucose. He's the man.
Yeah. And when I heard his numbers, I was jealous. So he's at least practicing what he preaches.
Well, he's got a cool backstory. He's actually he's a big time athlete. Big time.
Oh, really?
Oh,
I didn't know that.
Yeah. Oh, yeah. He was doing Ironmans, and he's a big. Yeah, you should get. He was a lot heavier, had a lot more muscle mass back in the day too. He's gone through a lot of experimentation on his own, and a lot of it's documented online too. He did
cool.
I remember seeing that stuff all the time when he would log in. He'd be on his ketone monitor or CGM monitor. He's a pretty interesting fellow. He's been doing this for a long, long time, but.
I'm scared to see what our glucose monitor readouts look like. I better step up our diet.
I know, gosh.
Jason, what were you doing on Thursday night at midnight eating cereal in the kitchen?
Oh man, it's gonna.
Let's see what a not a newborn, but a less than 1 year old baby does to a person's diet.
Yeah, well, adjust their cortisol levels and stress hormone. Jeez Louise.
Yeah, you're like, I wasn't eating at 3 a.m. I was up rocking a baby in the in the rocker.
Jeez. All right, dude.
Yeah, man.
Good.
Good talking to you, brother. All right, brother. Take it easy.